Thank you, and thank you for the organizing committee for inviting me to participate in this academy, Pancreas Academy. So today we're going to be talking about pancreatic enzyme replacement therapy in pancreatic diseases. Hopefully, I'm going to try to make it very clinical. So when you go back to your clinics, to your office, you're going to remember some of the tricks and things that we should be doing and thinking about when you're facing these patients. These are my conflicts of interest. So my intent today is to talk a little bit about normal function that was covered already in the first talk, which was a beautiful talk. Associated conditions with exocrine insufficiency. How do we make the diagnosis? Hopefully I'm going to convince you that this is a highly clinical diagnosis, and then we use certain tests and radiological imaging to make the final diagnosis. Indications and dosing on pancreatic enzymes. Very, very important. I'm going to try to stop in some of these slides and remind you this one is important to remember. And then we're going to talk about why they fail. And I'm going to show you that frequently they fail because we are making a mistake. So the normal pancreas, this was covered already, but I want to remind you that the amount of enzymes that are being secreted, it's going to depend with the content and the volume of the meal. The pancreas is going to do its job. The pancreas has a complex sensory and hormonal communication, and it's going to tell the pancreas to make the amount of enzymes that are needed. So now you start to get a sense of how complicated it can be to dose correctly these patients in order to increase the absorption in patients that are not making enough or patients that are blocked and the enzymes are not getting to the right place at the right time. In general, with every meal, the human pancreas will make approximately 720,000 units of lipase with every meal. Exocrine pancreatic insufficiency occurs when the gland is approximately 90% diseased. So this already gives you an idea that for you to have exocrine pancreatic insufficiency, the gland truly needs to be sick. And if everything looks completely normal, the likelihood that your pancreas is going to have exocrine pancreatic insufficiency, it's relatively low. Yes, there are exceptions to the rule, but I want you to get the big picture and the right message. So there's two different types of reasons why patients, two different types of etiologies for exocrine pancreatic insufficiency. The primary ones, which is that the pancreas is not making the enzymes, and the secondary one means that they're making the enzymes, but they are not getting to the duodenum. And this may happen because there's a ductal obstruction, like a tumor, stricture, and there may be also poorly synchronized enzyme release, meaning the enzymes are being made, but they're not mixing with food at the right time in the right place. And just as an example, patients with a gastric bypass with a Roux-en-Y anastomosis for weight loss would be a good example. They're not getting mixed, they're getting a little bit of, these patients are getting a little bit of malabsorption, thus losing weight. So what do we think when we're talking about primary etiologies for EPI or exocrine pancreatic insufficiency? By far, we're talking about chronic pancreatitis. There's many genetic conditions that have been mentioned throughout the morning. There's some inherited disorders of the pancreas. Occasionally, you have these patients with severe acute pancreatitis that most of the pancreas is gone because of the severity, and then they develop exocrine pancreatic insufficiency. Very, very important to keep it in mind because we're seeing these patients more and more and more. So again, a patient that had a bad episode of acute necrotizing pancreatitis, think about exocrine pancreatic insufficiency. By the way, think about diabetes as well. Other systemic disorders, inflammatory bowel disease, diabetes, this is something that is now more in vogue, celiac disease, von Hippel-Lindau, autoimmune pancreatitis, autoimmune particularly in the early stages. It's one of those that if you recognize it and treat it, the function will potentially go back to normal. What about secondary etiologies? You have tumor obstructing the main pancreatic duct. Unfortunately, we see this quite a bit, and these are patients with pancreatic cancers, the majority. Pancreatic surgical resections, partial, total, and here we're talking about benign and or malignant. Other surgeries like distal gastrectomy, gastric bypass surgery, as I just mentioned, there's not good synchrony of the enzymes in the food, so the food is being malabsorbed. Again, secondary causes, the pancreas is working well, the enzymes are there, but they're just not being mixed correctly. short bowel syndrome, and other systemic conditions like, again, celiac or gastrinoma. Gastrinoma is an interesting one because enzymes are very pH sensitive. So when the enzymes get in contact with a very acidic environment, they don't function. So they get destroyed. So this is something that it's important to remember when it comes to differential diagnosis. What you're going to start to see more and more and more are papers like this, and the data is starting to get stronger. And we're about to start a study actually looking at this as well. And the message is that when patients have pancreatic cancer and they undergo certain type of resections, and the one that was looked in this particular publication was Whipple, that 45% of patients, even before they have the surgery, they already have exocrine insufficiency, and I'm going to show you why in a second. And then after surgery, almost 90% of these patients will have exocrine pancreatic insufficiency. And what I'm trying to show you, if you look at the CT scan image, and let me see this pointer. If you see at the CT scan image here, you see the mass, you see a little bit of normal tissue in front of the pancreas or distal, and what you see behind, it's a dilated duct with a very atrophied gland. So here you see it again in this cartoon, the tumor, and again, this is a cartoon, but imagine this is very atrophied, and the pancreatic duct is very dilated. So what's the surgery that we offer to these patients? We offer a Whipple. So what do? We take whatever was normal, and we keep some of the body and part of in the tail as well, which is very atrophied, and it's not working well already to begin with. So the point that I'm trying to make is that when you do surgery for these patients, you're taking the little that was normal. So the likelihood that these patients are going to wake up and they're going to have exocrine pancreatic insufficiency, it's extremely, extremely high. So when you see studies like the one that I just showed you, they make a lot of sense. And not only that they make sense, but now you're starting to see the NCCN recommendations saying that any patient that has pancreatic surgery for malignancy, you should start them without even checking with pancreatic enzyme replacement therapy. And this is very, very important because there's also data that it's not too strong, but it's getting stronger with time, that patients that undergo, that are taking pancreatic enzyme replacement therapy and they undergo therapy, they do better than the ones that did not get pancreatic enzyme replacement therapy. So an intervention as easy and simple as giving enzyme replacement will have a huge impact on this patient population. So what are some of the symptoms of fat malabsorption? These patients develop abdominal pain. They may have already baseline abdominal pain, particularly if they have chronic pancreatitis. Remember, this is not always the case. Gas, bloating, everything that the patient is eating, or some of what the patient is eating, it's being catabolized, but the bacteria lower down in the GI tract, they're going to get very gassy and bloated. I can tell you this is one of the symptoms that significantly improve as they start to take therapy with enzymes. Unexplained weight loss should be a major, major red flag. This is something that is telling you this patient is losing weight. Something that you're going to frequently hear is that these patients are eating, but it's just they're not gaining weight, they're losing weight. The other thing that we see is that they have fat and protein malabsorption, and this is very important, long-term vitamin A, D, E, and K malabsorption. Out of all of these, the only one that we have strong data to support that plays a major role is vitamin D deficiency. To see patients with vitamin A, E, and K deficiency, it's extremely, extremely rare. Steatorrhea, once a patient develops steatorrhea, it's very easy to make the diagnosis, but you have wasted, or the patient has lost, a huge opportunity by the time that they develop symptoms, and the exocrine insufficiency became so severe to the point that they're seeing fat droplets in the stool. And I'll show you some images in the next couple of slides so you can get a picture of what steatorrhea looks like. This is just a couple of papers from 2010, 2016, showing the huge impact that not thinking about vitamin deficiency in these two publications, vitamin D deficiency, can lead to trauma, to fractures, to bone fracture. And in these two studies that had a large number of patients, what it showed is that when you look at patients with chronic pancreatitis and EPI, and you compare them to patients that have, for example, inflammatory bowel disease that have been taking steroids or celiac patients that we all know they malabsorb calcium, very high risk for bone disease. You compare the three groups, the ones that are admitted the most to the hospital with bone fractures are the chronic pancreatitis, because we don't tend to think about a metabolic bone disease in this patient population. So this should be one of your take-home messages. Look at a bone density scan, keep this in mind, because you may prevent a bone fracture in this type of patients. Excuse me. So other things to consider, again, we're talking about symptoms like foul smelling. For some reason, the smell of the stool of these patients, it's very, very bad, and that's something that the significant others usually bring it up to you. Bloating, gassing, weight loss, diarrhea. And what I always like to mention, and this is personal experience, and this is something that many of us have spoken among each other, is that frequently these patients actually have nighttime bowel movements. Patients that will wake up in the middle of the night to have a bowel movement, you'll hear it in patients with inflammatory bowel disease. You also hear it with this patient population. So something that they start to do unconsciously, it's to go to the bathroom before they go to sleep, or they start to have dinners around 6 p.m. or so they don't have to go to the bathroom at nighttime. You'll hear also some stool incontinence, stool urgency, and these are real symptoms. When we're talking about steatorrhea, it's always important to ask the significant others, because frequently patients just don't look. So when there's a lot of fat, it's difficult to flush, and the significant others may be telling you, yes, of course I see it, and the patient may be saying, no, I have never seen it. These are examples of, in this case, CT scan with chronic calcific pancreatitis. You see this big piece of rock, of stone, very large, with a dilated duct in a patient with chronic pancreatitis. This is another patient, an MRCP, with a patient with chronic pancreatitis, very dilated ducts, stones, side branches. This is a condition actually that we used to see a lot in our VHL clinic. This actually is a condition, genetic condition, that leads to a significant number of cysts in the pancreas. It starts to replace the entire gland, and next thing you know, these patients develop exocrine pancreatic insufficiency. They also develop diabetes. So these are conditions to keep in mind. This is actually an interesting patient that was referred to us with bloating and some weight loss, no abdominal pain. This patient was diagnosed with diabetes. And what you can see in the CT scan here, it's a big calcification actually that extends from the head down to the body of the pancreas. And you can see that the pancreas, it's almost completely gone, completely atrophied, secondary to stone disease. Non-smoker, non-drinker, the patient never had pain, and this is the type of cases that you see here and there, but it's the type of things to keep in mind. Excuse me. So how do we make the diagnosis? Clinical, as I just showed you, very important to take the extra 10 minutes and get a good clinical history. Imaging, very important. Remember, the pancreas has a big reserve, functional reserve, or at least that's what we think. So if 90% of the gland needs to be sick or malfunctioning to develop EPI, exocrine pancreatic insufficiency, you can imagine that you would expect to see a gland on imaging that doesn't look normal. Some of the testing that we can do, it's fecal elastase, for example, monoclonal antibody that we test the elastase of the pancreas in the stool, non-invasive, very good. It's actually the sensitivity. It's a little bit low, as well as the specificity, particularly early in the disease. But overall, it's a very good non-invasive test. 72-hour fecal fat collection. I think this is something that we rarely do. I would say that I have done it on clinical studies only. Elevated 13C mixture. We have actually 2 new breath tests that are not still commercially available in the US, but when you read the literature, this is something that is becoming more in vogue in Europe. It's not available now, we're not doing this test. Excuse me. What we can do also, it's a clinical trial, just give the pancreatic enzyme replacement therapy and see if the symptoms go away. And that's very simple to do, and that's something that frequently I personally do in my clinic. Suspect also that the patient may have EPI. If they have a little bit of symptoms, but you see that they have a low hemoglobin, low albumin, low prealbumin, if they have an elevated hemoglobin A1C, they may have some vitamin deficiency, just like we spoke, but it's rare that you'll see a patient just with the labs with symptoms and they don't have any other type of imaging study. So this is the pictorial part of the talk. When we're talking about steatorrhea, we're talking about a stool that is relatively well formed, it's pale, but what's interesting is the amount of fat droplets that you see around. And that's basically what steatorrhea is. Nowadays that everybody has a cell phone, I think it makes a lot of sense just to ask them, listen, can you take a picture? Because sometimes you're not sure if they have it or not. And again, you start to see the fat droplets here. You can see how it can be difficult to flush it, and you can see that it's pale and relatively well formed, and that this is not diarrhea. Again, this is, I would say, the extreme of a patient also with steatorrhea, that every time he or she eats fat, you're gonna see all these droplets of fat. And you know what, we're laughing, but I can show you another 20 images of this. I think I have a collection, so this is actually very easy to obtain nowadays. I think everybody has a cell phone that you can take a very decent quality image, and you can even make the diagnosis just by looking at the picture. So what are the goals of treatment? Of course, restore normal, or at least close to normal, digestion of proteins, fat, and carbohydrates, improve symptoms. As soon as they start to take these medications, the symptoms either are going to significantly improve or they're going to go away, and of course, maintain a normal nutrition. So what are the currently FDA-approved enzymes that are out there in the market? I'm not going to go into too much details. Now the list is a little bit longer, but what I want you to know is that all of the enzymes that are out there in the market now, they all work. They all underwent placebo-controlled randomized studies to be FDA approved. So they all work. And this is the different time frame at which they have been approved over the past couple of years. I'm not going to go into too much details, but this happens to be one of the studies that was done. Again, I could have shown you any studies of any of the other pancreatic enzymes. They all underwent placebo-controlled randomized studies to show that the coefficient of fat absorption was greater than 80%, and they would meet, the FDA standard, minimal standard, to be able to get approved. Something that is important to know is that when you compare the side effects with placebo, throughout the publications, they were exactly the same, which means that these medications are very, very, very safe. This is actually a 68-year-old patient, just to show you another real-life patient that was recently diagnosed. I think it was like 5-6 months with exocrine pancreatic insufficiency. Was started, rightly so, with pancreatic enzyme replacement therapy. I don't know how many of you have electronic medical records. I'm assuming the vast majority. When you put whichever enzyme that you like, the vast majority of the time, even though you may tell the patients take it at the beginning, at the middle, or in the middle and at the end, you're going to see that the printout, in case you haven't seen it, it's going to say take it every 8 hours. So that's how he took it, every 8 hours. And the doctor was a little bit conservative for no reason and was starting the patient on a low-dose pancreatic enzyme. So he decided to come for a second opinion, and he already had the picture without me asking for the picture of how his stools look. And he told me, doctor, I'm taking the enzymes, I'm doing everything like I was told. So here, actually, you can see a patient that is compliant, but the treatment is not working. Why is the treatment not working? The patient is being under the amount of enzymes, it's way too low, underdose, and you don't take this every 8 hours, you take them always with meals. Because if the enzymes don't mix with the food, there's no way they're gonna work. So there were multiple mistakes that were made secondary to technology, and the underdosing, to me, has no excuse. The patient was being treated with a pediatric dose. So for those of you that are dealing with adults, always use the higher presentation of whichever pancreatic enzyme you like to use. So what about what's the best time to take the enzymes? I'm just showing you this, so hopefully I can convince you that this makes a big difference. This is a study that was done by Dominguez Muñoz many years ago, so I'm not talking about anything new. This is something that we have known already since 2005, that the highest efficiency of the enzymes is when you take them throughout the meal. Second highest, it's just after the meal, and the lowest, it's just before the meal. So what many of us tell patients, and this is based also on consensus statement, it's to take the first dose in the middle of the meal or after a couple of bites, and the second dose immediately after when they're done with their meal. So that's how we dose these patients. Very, very important. So the enzymes mix with the food, and there's gonna be good absorption. So just to finish, why do these enzymes fail? So what we see the most is that some doctors are afraid of giving the right dose, and they start to give pediatric doses and slowly increase. Again, this is a mistake. I think most of us will start in the right dose. And the typical example that I like to give is that if you have a headache and you know that a gram of Tylenol will take the pain, the headache away, you go straight with a gram, and you don't go with 250, and then half an hour later, 250, and then after 2 hours, you're taking the right dose, and the headache goes away. So right dosing is extremely important. Compliance with therapy. Frequently, it's too many pills too frequent. So patients just don't take it because of social issues. They don't want to be in a restaurant or with friends and take the enzymes in front of them, and that may be an issue. They may be still drinking or smoking heavily, so there may be still a lot of inflammation around. The other one that we see a lot, particularly in patients that have undergone surgery, it's motility disorders. Sometimes we're placing nasojejunal feeding tubes in these patients to give them some time in order for the motility to go back to normal. Very rarely we're doing PEG or pages, and we strongly discourage the use of TPN. And if they have rapid transient, you can give Lomotil, Imodium, Tintum of Opium to try to decrease the motility. Always, if you have ruled out all of the above, always think that these patients may have a superimposed condition. And the one that we tend to see the most is small bowel bacterial overgrowth. Giardia, it's rare, but we see it occasionally, celiac, and so. So just think about small bowel bacterial overgrowth, rule out the others just to go by the book, but I tend to give these patients the antibiotics so they can take it immediately when they leave my office. And in my personal practice, I'm not documented small bowel bacterial overgrowth. I'm going straight to treatment. So to finalize, what are the challenges that we have for the future? Again, we do have the right amount of enzymes for the particular meal. This is important. I didn't go over this, but frequently when you have an educated patient, you can tell them that if they're just having a snack, for example, that it's a tea and a cracker or something like that, they don't need to take the full dose. They can potentially bypass the enzyme. So with time, patients learn also how to dose themselves so they can take more or less depending on the amount of fat that it's in the meal. The size of the pill is something that we frequently hear that it's too big, and that may be a reason why compliance goes down. The other issue is that it's too many. They need to take 2 with every meal, 1 with snack, and this also it's an issue. Synchronization, GI motility, as we spoke before, particularly in patients that have had surgery, and patients, and the other issue that we don't know the answer yet, it's concomitant use of acid inhibition. Most of these enzymes come with a protection for the pH of the stomach. So once the pH is above 5, they would open in the duodenum so they can start to act. Some people think, and again, this is something that I sometimes do, it's to give a PPI to make sure that the enzyme it's opening and releasing a little bit higher up to see if they have any effect. This is controversial, but this is something that many of us do in the real world. So to conclude, it's important when we're talking about exocrine pancreatic insufficiency and pancreatic enzyme replacement therapy. This is a clinical diagnosis, and we use imaging and labs to make the final diagnosis. Again, I cannot stress enough how important it is to use the right dosing. If you treat adults only, always use the highest dose of the presentation of the enzyme that you like. Remember the interval. Just tell the patients these enzymes work when they mix with food. If you are not eating, don't take them. If you're eating, take one in the middle and one at the end, as the study that I showed. Individualized based on clinical symptoms. Yes, you can change a little bit the dosing, and lack of clinical response should trigger a workup for other medical conditions. And what I want you to remember is small bowel bacterial overgrowth. And just as a last slide, take advantage of this website from the National Pancreas Foundation. This is completely free. You can log in here. We have videos that teach patients, medical care providers, family members, patients, on how to take these enzymes in a cartoon. And this is actually something that I have found to be extremely helpful for our patient population. This is our new Cancer Institute, and with this I'm going to stop, and thank you so much.